There we go. Grief. It's like 7 different cameras. Y'all want to know what the worst camera is? Is the selfie camera. I've never seen my face look so just not great, except whenever you like accidentally hit that selfie camera on your phone, you know what I'm talking about? And it's like you're holding it. You're like, whoa, good grief. I look rough from this angle. Nobody thinks that's funny. I guess it's just me. That's cool. Can y'all hear me? Oh, I'm just not funny. I get it.
Yes.
I get it. I'm just not funny. I'll work on my jokes. Um, all right. So, um, thank you all for your patience last week. That was a rough week last week with my whole family getting sick, including myself, and then my our AC going out. Yep, and my postdoc being out on vacation, plus discovering that Blue Cross randomly kicked me off their panel. Not kicked me off; they just took me off their panel, which caused about $6,000 or $7,000 in insurance claims for services I've provided for patients to be denied. Um, and so that was real fun. Um, we're making it. We're in a better place this week, and hopefully won't have to ever repeat that week again. But um, I want to recognize that we've got uh, quite a bit that we could cover tonight. And typically, what I do in week 5, and really the game plan that I'd like to do tonight, is give you all the opportunity to um, ask questions related to like practicum, internship, licensure, um, and then really and truly private practice related questions if anybody is planning to go to private practice at some point, where, for the most part, or any and all questions related to how to start a private practice, what are some obstacles, what not to do, especially. Um, and so I want to give space to that, but also make sure that we have enough space for y'all to ask questions related to the topics from weeks 1 through 5, which is quite a bit. And again, I want to recognize that we didn't have a chance to meet last week. And my hope is to try to fit in one more class somewhere. But if we don't, we still have plenty of time, since we're meeting on a weekly basis from here on out, to get everything covered. But with that said, I do have obviously last week we don't have anything recorded for class, but the week before last, the 25th of September, I did post that recording in Moodle finally today, and I apologize for how long it took. Promise it won't take that long from moving forward. Um, but just wanted to let you know that that is posted now, and this is being recorded tonight. So I'm going to try to get this posted either tonight or tomorrow. So I will get better at that. Um, before I open it up to questions related to any of those topics, does anybody have any other questions, like practical questions or concerns, or um, things that you'd like addressed? Gabriella? Yep, go ahead.
Hello, teacher.
Hello.
I hope your family is better now.
Thank you. We're making it, and pretty sure we all had COVID by the way.
Oh my gosh.
Yep.
Yeah, I heard some people is having COVID now. Yeah. Can you hear me good?
Absolutely. I can hear you perfectly.
Okay.
Yep.
Sorry about my accent. I'm from Brazil.
Oh, no
And
worries.
I'm still struggling with the English, but I'm getting better.
Your English is great. I'm assuming you know Portuguese, right?
Yeah, I speak
Yeah.
Portuguese. Yes.
Sweet. That's awesome.
So I'm just confused with the weeks. So today we are in the week 5.
Hmm.
Okay. I don't know if you can talk more about the ATD
Hmm.
because um, I I think it's very interesting, and you have too much knowledge on it. I don't know if you can talk more about.
Absolutely. I would absolutely love to too, because it's a passion of mine. And um the uh
You told
well,
that you had one meeting. I don't remember the name. The meeting that you went to you
yes,
yeah,
the conference that I spoke that I presented at.
yes.
Yep. Let's see if I can pull up those PowerPoint slides and share those. I believe. Um, while I'm doing that, are there any specific things that you want me to focus in on? Because I mean, literally, I could talk about ADHD for the rest of probably my life at this point. But is there anything in specifically that you
Yeah,
would?
I was reading that DSM is not covering too much the social interaction,
Mhm.
and the psychological problems that the people who has ADHD have. I don't know if you can talk more about that, the social and the emotional area.
Sure, absolutely. Um, here we go. I think.
I
Ah,
have one with ADHD, and I have a special interest in that. Uh,
sure, absolutely. Um, I'm gonna have to dig up those slides somewhere because I've got so many files on my computer. It's not always easy to track things down, but I can talk about it anyway because it's not like you just be staring at the slides while you're listening to me anyway. So, um, so I would say first and foremost is understanding that the DSM-5 TR outlines that ADHD is a neurodevelopmental disorder, meaning that it is supposed to, well, I would say it's a disorder affecting neurodevelopment. So the DSM-5 tries to imply really that it's a disorder that is supposed to not only occur, but begin during the neurodevelopmental period, which is essentially from conception through like age 25. But they want to have they have like real technical specifications about when symptoms were supposed to be present, right? I think it's age, was it age 13? Is there,
Around 12, I think it's
yeah,
12. Yeah.
is there cutoff? That doesn't mean, well, so that's technically true per the DSM-5, but there's not a lot of great research to support that random cutoff, just so you know. Um, in other words, symptoms may not always be overtly present or like observable, sometimes not even until adulthood. And that's where you hear things like the adult onset subtype and or not subtype, the adult onset ADHD. Well, the truth be told is that ADHD, there are many roads to Rome, so to speak. So you've got ADHD is a general class or categorization of behaviors. You put, you know, attention difficulties together with either hyperactivity or impulsivity or just one of all three. that cause enough dysfunction across either school, social relationships, functional independence, right? Or the acquisition of like age appropriate developmental skills or academics. If those symptoms affect those domains enough, that is how you end up with a diagnosis of ADHD, regardless of what is causing it. Now, I'm going to say that again. So, in other words, ADHD is predominantly a genetic syndrome, meaning about 60 to 70% of why somebody has ADHD in most cases is related to the genetic predisposition for such. The other 30%, explanation is going to be environmental factors like whether, exposure to some random chemical while in utero, or maybe early childhood sickness or whatever. But in most cases, your family tree is tracking genetically ADHD. Now, that's not all cases. And sometimes there's 0% genetic predisposition, but you could have a brain injury at birth that, well, let me say this before I finish my sentence. Anything that affects the body physically, either in severity or length of time, especially for young kids between birth and age, let's just say age 10 or 12, anything that affects the body physically and or the brain, which is part of the body, is going to affect the frontal lobe development. Because the frontal lobe is the most vulnerable part of the brain. It's the most sensitive to environmental input, just so you know. And when I say environmental input, that also includes, physical sicknesses, injuries, and trauma, chronic stress. So, in other words, going back to my point, sometimes you can have 0 genetic predisposition and have enough environmental factors that produce a developmental trajectory that's abnormal for the frontal lobe to the extent that you manifest ADHD symptoms, which is still ADHD.
I got it. So if someone can have some injury and can develop the ADHD.
Mm-hmm. Absolutely. And which is also, it'll make sense in this way. So most people are probably familiar with cerebral palsy, right? Like you've probably heard of cerebral palsy before, where while in utero, the baby is exposed to like a lack of oxygen in some way, and what ends up happening are like speech and motor deficits, like that are very apparent. But a lot of times, cognitively, IQ wise, they're everything's pretty normal. It ends up being a lot of just motor control. And with that said, I can tell you almost every person with cerebral palsy is going to have quite a few ADHD symptoms. They may not meet the full diagnostic criteria, but I can promise you their frontal lobe is on a different trajectory than what it would have been had they not had the lack of oxygen.
Mm-hmm. Makes sense.
And the cool thing is that the earlier in life that the injury or illness happens that affects the frontal lobe, the more time we have for the opposite to occur. So if, let's say you have cerebral palsy and it affects the frontal lobe development, if we treat, at least this is the theory, if we treat ADHD early on and identify it early on, because we've got, up to age 25 or so for the frontal lobe to develop, there's a good chance we can get that person to grow out of ADHD into adulthood.
Mhm.
That's where, Russell Barkley quotes us a lot. It's like one third of all kids and adolescents who are diagnosed with ADHD end up growing out of it. That's with or without treatment.
Mhm.
And though I've yet to see the actual science that proves this or supports this opinion, I would just say logically it makes sense that, well, if one third of them grow out of it with or without treatment, if we actually do treatment right, there's probably a good chance that we're going to increase that chance of them growing out of it. So maybe 50 or 60% grow out of it if we
Mhm.
treat it.
Mhm.
Now, that's the kind of bits of information that you won't read about a lot online, because when you read about it, it's like, well, ADHD is a lifelong disorder and blah, 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 but not necessarily. And ADHD as a diagnosis hinges on how it manifests through dysfunction. So, like, you could have an ADHD brain, but if you're doing okay with academics, if you're doing okay with social skills, if you're doing okay with like functional independence and like age appropriate like abilities, if you're doing okay with all that stuff and at work and so forth, you don't have ADHD, even if you've got an ADHD brain.
Mhm.
That's the confusing part, because everything you read is like, well, ADHD is ADHD is ADHD, but it hinges on how it causes dysfunction. All of that implies, though, that we live in a perfect world designed around our brains. And folks, when people ask me, well, how come after COVID, it seems like everybody has ADHD now? That's because our brains went through some stuff, a lot. And
Mhm.
we are living in a very stressful world post COVID, for that matter.
Mhm.
And there are personal challenges and responsibilities that have returned in full force post COVID, where a lot of people, and kids included, um, are seemingly expected to perform at pre-COVID levels cognitively. And if you ever caught COVID, I can promise you it did affect your brain in some way. Doesn't mean that you have dementia or anything like that, but it might not be measurable officially, but it did make it to your brain. It did cause dysfunction. And we don't really know what that means for kids or adults yet, long term, exactly. We just know that it does. With all that said, to answer your question about the social, emotional impact of ADHD, things like that for kiddos, especially, one of the main things that I would want you to know is that it's important for us to identify ADHD as early as possible and start intervention as early as possible, because it can cause, gosh, what I'm trying to say is it can cause a kid and an individual to internalize shame. Because if you think about it like this, like if, and I see this with like kindergartners, by the way, a lot. Kindergartners with ADHD who don't have a frontal lobe that is age appropriate just yet will go to kindergarten and become disruptive and start the process of being conditioned to anticipate getting in trouble, first of all, at school. And in other words, conditioned or taught that school is a place of pain. Then you put them around other peers who are also kindergartners who don't have the greatest social judgment to begin with, who are very rejecting,
Mhm.
such that this child with ADHD begins to get conditioned to anticipate rejection from peers, even on an unconscious level. And when I say conditioned, I mean it like like unconsciously conditioned. It's not like you can ask a kindergartner, well, have you learned that your peers are going to reject you? They're not going to know what you're talking about. But their brain is being trained or conditioned is the right word to use to anticipate rejection from peers. And the longer that happens, the stronger that becomes through middle childhood. And especially you start to see it show up in adolescence with um, kiddos being drawn to other kids with ADHD because that's the only group that won't reject them. And usually those are the kids that, if it's untreated and it's substantial enough, are the ones getting in trouble, sensation seeking, doing all kinds of conduct stuff that ends up being dangerous.
Mm-hmm. Mm-hmm.
And from there, I want to highlight this other point, and then I'll pause and let y'all ask questions. But from a social emotional standpoint, think about attachment style. We're given one kind of initially just from birth. And then that first year of life is really important. Then from there on out, it increasingly becomes molded by peer interactions. Well, if you've got ADHD and you start to internalize like, well, I'm a bad person, right? Because I'm always getting in trouble. And it's not even a conscious thought, just becomes internalized. You do that long enough, you can either go one of two ways. You can either respond with depression, which you'll see a lot of kiddos do, and you'll know that it's depression because you'll start hearing self-deprecating comments like, I'm so stupid, or I always do this, or whatever. When you hear that, I want your ears to perk up. You don't have to immediately jump to ADHD, but you need to immediately jump to, this kid may have depression. Mm-hmm. Yep. Because that's how it comes across. They start saying self-deprecating stuff and anger and irritability. But so once they start internalizing that, they can either become depressed, or they will find the one thing that they're good at, mm-hmm. and will latch on to that to beef up their ego, their self perception, to not feel so ashamed all the time. And I'm here to tell you that's the budding of narcissism. Mm-hmm. Mm-hmm. I'm not saying everybody with ADHD ends up with narcissistic personality disorder. I'm not. What I am saying, though, is most of us have more than average narcissistic traits in response to this underlying sense of shame that we're trying to prove wrong. Mm-hmm. And on top of that, ADHD affects the frontal lobe, and particularly the part where self-awareness is, especially self-monitoring in social situations. And so even neurologically, there's a narcissistic quality because there's a level of selfishness from a neurological standpoint, because we can't always be aware of how we're coming across, can't always be aware of what others might be thinking or feeling, or how others might feel. And so there's like on average, there's lower empathy for ADHD for that reason. Mm-hmm. And then, I'm sorry, the very last thing, I will pause. Along those lines, that self-awareness often goes hand in hand with what's called alexithymia. Mm-hmm. And I'll put that in the chat. Mm-hmm. If you ever want to name like your pet that, you should, because I always thought that would be a cool name, alexithymia. And what that means is the inability to be aware of or read one's own emotions. Mm-hmm. And most kids and adults, for that matter, with ADHD have a harder time recognizing their emotions unless they are extreme. Mm-hmm. But by then, they've already done the damage with their emotions, mm-hmm. which is where the guilt and shame comes back in, and this internalization of like, there's a indirect conditioning that happens to become even less, or to become even more dissociated from one's own emotions. Mm-hmm.
Yeah,
Okay. I'll pause right there for a second.
thank you so much.
Um, that I just was kind of rambling. I'm hoping that answered your questions.
Yeah, that was very good.
Okay.
Thanks.
I've got more too I could always talk about, but I'm going to pause right there. Anybody else have questions related to what I just talked about? It's hard to hear everybody at once, so just kidding. Um, Let me highlight this is that when you really dig into the ADHD stuff, you're going to start to see it in everything. I'm just telling you because ADHD in kids, well, I'll put it this way: mental illness in kids and adolescents, right? Mental illness in kids and adolescents is going to produce chronic stress. Everybody agree with that? More stress than average, anyway. Well, biologically, does anybody know what is stress biologically? Like what's the stress hormone?
I don't know, sir. I don't know. I don't know if I know how to
So,
Cortisol, yeah. Yep. And by the way, cortisol, um, another word for that's called corticosteroids. I know it's another word you can name your dog, but it better be a big dog though. Is what I'm saying. Corticosteroids. Um, well, as y'all know, so steroids. Why are we given steroids whenever we're sick? Sometimes, what do they do?
to fight inflammation.
Mm-hmm. They suppress the inflammatory response, which is good if you've got like some sort of autoimmune something happening, right? If your body's like hurting real bad, it can suppress the inflammation response, which is another way of saying suppress the immune response. Just FYI, it's an immunosuppressant, but in the short term, cortisol acts as a uh, corticosteroid by inhibiting, like if you had like a backache, for example, and a bear started chasing you, well, you don't really want your brain to prioritize that backache. You kind of want your brain to forget that you've got a backache and that remember that, hey, I was young once and I could run fast once. So let me get back to those days as fast as I can. I'll worry about my back later. Right. So when you're in a fight or flight mode, that stress response produces cortisol and the corticosteroids in to suppress, in the inflammation through the body to make you feel more energized, to make you feel less in pain and ready to fight or flight. Um, when that happens in the brain in the short term, you get a boost to dopamine and norepinephrine. In other words, if you were sleepy before, I doubt when you see that bear chasing you, you're going to stay sleepy very long. You're going to be alert. It's going to wake you up, right? If you've ever woken up in the middle of the night to like a loud noise, like you sit straight up and you're like, you are awake. Then usually when that happens, you have a hard time falling asleep, right? Because dopamine and norepinephrine are pumping through your brain. Another word for norepinephrine is noradrenaline. And just remember this: cortisol and adrenaline kind of work together. So you can't ever have adrenaline happening without cortisol being present. All right. With that said, cortisol is supposed to decrease as your fight or flight like system kind of decreases. You get away from the bear. The problem though, when you have chronic stress, especially like trauma, especially trauma, by the way. Trauma triggers that fight or flight response, and then it kind of stays on instead of turning off, which means that we've got cortisol flooding our body and our brain. And in the long run, cortisol suppresses the growth between neurons or the connections between neurons. And on top of that, the connections you did have, if you have the cortisol in there long enough, it degrades it and literally will kill off neurons and break down the connections that were already formed. That's why people who have chronic stress will always complain of memory problems and attention problems, things like that, literally because their brain is losing connections. It's what depression does to everybody's brain, just FYI. And that's how it does it. So imagine having that happening while your frontal lobe is also trying to grow. It's not going to grow as swiftly as it should. Everybody agree with that? It's not going to mature as swiftly as it should. So I'm telling you all this because as it relates to things like ADHD, when we talk about mental illness in kids, the backdrop is that we've got this stress response happening in the brain that's interfering with the frontal lobe's development, which is why many kiddos with mental illness during childhood, if left untreated for long enough, will develop ADHD symptoms as a result. Whether or not they meet, DSM's official diagnostic criteria, just depends on what all is happening. But they will have more ADHD symptoms, and that's why you'll also see a lot of ADHD symptoms present with things like childhood PTSD or childhood depression, anxiety disorders, and so forth. What I'm not saying is that every kid with mental illness has ADHD. What I am saying, though, is that if left untreated, it will change the trajectory of that frontal lobe enough to where it could be the direct cause of ADHD later. Does that make sense? That's why I always get a little bit, not like mad, but it's kind of my pet peeve that I'll hear a lot of people say, well, ADHD is getting overdiagnosed and we don't recognize trauma enough in kids. Well, while I agree with that on both sides of that equation for that matter, I also want to not throw out, I don't like this term, but the baby with the bathwater, right? Because in most cases of childhood trauma, it is such that we've got a cortisol like dysfunction happening over an extended period of time, which almost in all cases will cause that child to develop ADHD pretty swiftly. But it doesn't mean that you can treat the trauma and that the ADHD goes away because it's already done its damage or change. But what it also does mean, though, is that you do have to treat the trauma, because if you don't, it's just going to make the ADHD worse over time. And you're going to decrease the chance of that kid growing out of it into adulthood. And so while it's not, it's not the answer to give a kid with trauma a stimulant, it is the answer to be very vigilant about the possibility of them also having an ADHD thing happening that's co-occurring that you should also treat with the trauma simultaneously. But a lot of times you'll hear people say, well, if you just treat the trauma, it all gets better. That's a great story. It's a great theory that I've never seen in practice. Never seen it. I've seen kids get treated for trauma, which is awesome. And then usually they'll still be in need of treatment for ADHD because it's still ongoing. Again, I'm not saying that every kid with trauma has ADHD. I'm just saying that they are more at risk for meeting the arbitrary cutoff diagnostic system that the DSM-5 defines as ADHD. And neurologically speaking, there's no doubt that that trauma has interfered with the trajectory of their frontal lobe's development, which may not be enough to show up during childhood and adolescence, but it might show up in early adulthood. Especially when college hits, or if they get married and they have kids or get their first job, that kind of stuff. Yeah. But if you read the DSM-5, it'll say all those symptoms were supposed to be present before age 12 or whatever it is, but they won't always be, because a lot of times you have parents who are surrogate frontal lobes, right? So like they're making straight A's, but that's because mom and dad are, staying up till 10 p.m. like feeding them chocolate candies just to get them to finish their spelling homework every night. And if they didn't do that, they wouldn't be doing as well functionally. Yeah. By the way, the worst time to assess kids and teens for ADHD is at the end of the school year. Because I'm here to tell you that on top of everybody just being ready to be out of school, the kiddos are especially. But if you ever get any of the input from the teachers, I think I told you this last time, um, the teachers will all like you could have the perfect angel, student in their class. And I promise you, you give them a questionnaire for ADHD, and that kid's going to be the worst ADHD kid they've ever seen, because those teachers are tired. All the kids have ADHD as far as they're concerned at the end of the school year. Yeah. And especially right before the STAR test. Yeah. So is this helpful information for you? Awesome. Let's talk about ADHD medications real quick. I think that's going to be important. I know we've got a bunch of DMDD stuff to talk about, and mood instability, those kinds of things, but you're going to come across the medication piece quite a bit. All right. Long story short is ADHD medications have a bad reputation in the general public and amongst clinicians, mostly for three reasons. One, the generations that are adults now, let's say in their 30s, 40s, and 50s, were the first generations ever to be officially treated with medication for ADHD. And back then, there wasn't, well, I'll just say there just wasn't a lot of information about how to do that well. We just know that sometimes it did work, but most of the time you would end up with kids with zombie kids, right? Their personality would be flat and whatever. And so we've got a generation of folks that are now clinicians, parents, who look back and say, oh, I would never want my kid to be on medication because it turns kids into zombies. Well, if you think about it, we didn't have enough information really to do it well, on top of the fact that most of the bad things that happen as a result of those medications are related to the other two things, which is pediatricians and family doctors are the number one prescribers of ADHD medication and not specialists. Nothing against those clinicians. They are doing the best they absolutely can, trying to do it all, because there's not enough psychiatrists, especially not enough psychiatrists that specialize in pediatric stuff. So, of course, just by chance alone, most of them aren't going to do a great job at it. Everybody agree? Which also means that they probably didn't do a great job at diagnosing it to begin with. Right? Then you also have non-specialists who don't or haven't or don't have the time to stay on top of the emerging research on all the medications, because I'm here to tell you that in order to do it well, the medication has to be tailored to the individual. And as it relates to kids, the younger they are, the more often you're going to have to change the dose or change to a different medication. And there's a lot more side effects that can interfere with things like eating lunch or gaining weight, growing appropriately, or sleeping, right? Yes, Aaron.
I have a quick question. If that seems to be the outcome, is that there is not enough clinicians available for the issue at hand, what, I mean, especially for pre-adolescents, um, what is your suggestion, I guess, moving forward as a society? I get a Western United States society for children who are wrestling with it, but obviously don't want to get pre or just what's the word, prescribed the wrong or incorrect ADHD medication, which will affect them long term. Yeah, I'm just curious to know your thoughts on that.
Well, from a personal standpoint, that's why I went back and earned my postdoc master's in clinical psychopharmacology, because that allows me to prescribe in certain states, and eventually it will be Texas, but it'll be a long time coming. But more just globally, I would say is that we've got to we've got to educate the public really for the funding, and the government for the funding for more pediatric psychiatry like opportunities. We've got to educate the public in relation to the anti-medicine like kind of culture that has become a part of the US, especially as it relates to psychiatric meds. Is like this weird like psychiatry voodoo, like psychiatry or big pharma's out to get us all with their Prozac. Um, we've got to educate, as counselors, as non-prescribers. We have to educate, and then on top of that, empower our patients with up-to-date research that they can see themselves and read for themselves. And then when and if they don't have the opportunity to see a specialist, I'm telling you right now, most of my patients leave my feedback sessions after I've gone over their diagnosis. They know more about the medications than their general practitioner do. And so they will often bring those resources to their general practitioner. And if they're good enough at what they're doing, that GP or the pediatrician will actually look at it and be like, okay, well, I mean, this makes sense. And so let's try to follow at least what this is saying. And it doesn't work all the time, but it's a lot better than just either them assuming that they know what they're doing, or yeah, or just just shooting from the hip. So I'm not sure if that answers your question, but as counselors, I think a lot of it's going to be empowering your clients to push through their own bias and to help them find, and I mean, really, it's going to be on you too to find the prescribers that you do trust, who can do it well enough that in most cases doesn't produce those terrible outcomes. Yeah. And I've got a short list of people that I trust. I mean, I'm telling you, even me and my own psychiatrist, I know, and he knows that I know more about this ADHD medication than he does, but we still wrestle around with it because he's the prescriber and I'm the patient, right? And but it's more of a matter of just empowering with knowledge, honestly. Yeah. Does that help, Aaron?
Yes, I guess just one follow-up to that. I mean,
Sure.
obviously, that's in an ideal world. We have all of those resources and the knowledge, and obviously, that's something hopefully we can get to. Even in this class, and you talking about it makes me want to go do that.
Sure.
But in the meantime, with children, pre-adolescents, and things like that, um, do you have, I don't know, I guess I'm curious to know your thoughts on if you would be more inclined to not prescribe, overprescribe, or, trust or not trust your doctors, even though you just said that, we need to trust to get rid of that culture of distrust. But you also just said you had to short list
Right.
yourself. And so I'm just curious to know how you would go about if a 9-year-old or 10-year-old walks into your office
Mhm.
and you're like, should I prescribe or not? Prescribe as like a teacher or someone like that. Are you more inclined to not prescribe over prescribe, or are you more like, hey, I think you should get on some type of medication?
In most cases with ADHD, um, I, well, number one, the science says that when it's done correctly, it is the most effective treatment. Even you can't even compare it to like behavioral intervention, because behavioral intervention, at least in theory, has no um, benefit, at least not in theory. I'm sorry, based on the science. Now we all know. I know we don't want to hear that as therapists. That's what the science says, and especially as compared to medication when done correctly. But to answer your question, is a lot of times these folks that I'm working with anyway, the parents, when you teach them what you know about the medication, when you encourage them to say, hey, listen, you know, kids are a moving target. So just because there are side effects doesn't mean there will always be side effects. And when you start like educating them, you begin to increase the chance that they're going to ask the right kinds of questions to their pediatricians, if that's the only person that you can find that will prescribe. Um, and then if there's absolutely nobody that you trust, which is in most cases pretty rare, that you can't find at least some pediatrician out there that has more specialty training in it, or a pediatric psychiatrist somewhere that does. Um, if you can't do that, which is true, especially in the rural areas, um, the next best thing is to work on the executive functioning front by educating teachers, parents, doing your play therapies with integrated like executive functioning interventions into it, knowing that you're never going to be able to outperform what you're neurologically capable. And so, in other words, when the medication isn't present, there's a limit to which that child is going to benefit from behavioral interventions, simply because their attention span, let's just say, is at 70%. Whereas if it were at 90%, it would be gaining that much more, or have that much more benefit from behavioral intervention. But I'll tell you, just in practice, most of my patients, I either have direct access to helping the pediatrician, like I do that a lot. And by the way, as counselors, you'll be asked to do that a lot. You'll have pediatricians ask you, well, what do you think we should start them on as far as medication goes? And you're like, well, I don't know, applesauce. I mean, like, I'm not a physician. That's what you want to say. But the more you can get to know it, the better, because you will be asked those questions. And to be honest with you, the little that we've talked about it so far is often way more than the training than most of the prescribers even have. And so anything that you can contribute that is based on science is going to be that much more beneficial. But all the resources are out there. I'm pretty sure I've posted in Moodle the most up-to-date versions of like the overall ADHD medication guide. But if I haven't, I'll certainly do that. And so I'm not sure if that answered your question, but in most cases, I always recommend medication. It's never going to be perfect with kids because it's a moving target, but it can be done and adjusted. Well, I'll be honest with you. The answer to that is usually we can't just meet once a month to go over how it's working. The younger they are, the more often you're going to have to meet with parents to be adjusting medications and changing things up to avoid the side effects, like not eating and not sleeping. Yeah. And then the last thing I would say, what makes it even more complicated is managed care and whether or not they're going to cover a certain medication over another, even though one might be better clinically. Yeah. I don't know if that helps.
And I don't know if I see it, and y'all can correct me if I'm wrong. If you wouldn't mind reposting
Yeah.
the prescription medication.
Oh yeah. Yeah. Let me do that right now before I forget, because I have ADHD and I forget. Let me see. Yeah, I wish I had a better answer for you. That was honestly more optimistic. Aaron, it is hard to find good prescribers. That's just point blank. I think the answer is training the people that are prescribing right now incorrectly how to do it better. And I mean, obviously, for those of us with additional training, maybe allowing us to do it too. But yeah. All right. So I'm going to put it in week 5, just so you know.
Thank you.
Uh-huh. Upload that right now. Any other questions on that at all?
I have a lot, but
That's
I
okay.
don't know if I understood right. You say play therapy with executive function training. You told something like that.
Mm-hmm.
And can you talk more about that?
Yeah. So what I always recommend, even though the research says that it doesn't help at all, for kids and adolescents, is to remember that kids without ADHD are going to need somebody in their environment to help them self-monitor enough to know when to use the skills that they learn, right?
Mm-hmm.
If you're planning on providing therapy for kids with ADHD, take their chronological age and subtract their maturity level by about 2 to 3 years. That's going to be your approach to therapy. So if you've got, let's say, a 10-year-old, you're going to have to get a little bit more concrete with how you provide therapy to that kid, simply because their frontal lobe is going to be lagging behind in development by about 2 to 3 years in maturity.
Mm-hmm.
Then recognizing that we've got a disorder of self-monitoring and of attention, such that how they learn in play therapy and how they learn in that 1 hour a week that you have with them is going to be negatively affected by the disorder itself. And so you have to prepare your sessions with them to be a lot more stimulating, a lot more engaging,
Mm-hmm.
and a lot more organized. And like, you can't go in there with like open-ended, like Yalom. You have to be almost like a coach, like a teacher, where you've got an agenda that you're going to get these objectives done. and you're going to be ready to be on the spot with any kind of transitions or switching of tasks. And also be considerate of what time of day that you're working with this kid, because a lot of times kids are in school and then they come to therapy in the evening after their meds are wearing off. Like, I mean, good luck with that. It's going to take twice as long in therapy for that to work. And then on top of all that, there are resources that I've posted in Moodle. I know I've seen them in there, like executive functioning interventions with kids and adolescents and things like that, that you can integrate into your own style of therapy, whether that's play therapy or whatever. But those parents, those caretakers, the guardians, whoever brought them to therapy, you had better keep about 15 minutes of their therapy session at the end to go over what you're working on with that parent, because you have to teach them how to be a therapist at home, because that's their best chance at benefiting from all this intervention, because you get 1 hour a week to shape that frontal lobe. And just like a piece of clay, if you've got 40 other hands shaping it the rest of the hours a week, all you get is 1 hour a week to shape it. No matter what you do, it's going to be undone by the rest of those hands, so to speak, unless you train those other hands how to do what you do.
Makes sense.
And so the executive functioning piece, understanding what's developmentally appropriate, first of all, also understanding that our school system and most parents are going to expect their child or those students to, in ideal situations, to meet age appropriate expectations for personal responsibility with or without ADHD. But what we know is if that kid has ADHD, they ain't got that neurological capacity to do it. In other words, they're confronting a system on a daily basis where they're being asked to perform well beyond what they're neurologically capable, and then getting in trouble for it. And so ideally, as a therapist, you would have some sort of means of helping the parent learn about these things so that when they see it at home, especially because it's hard as a parent to eyeball your own kid, but it'd be nice to know, like, okay, is this my kid having an executive functioning limitation, or is this them just being a normal kid? Because what ends up happening is parents will see it all as them just being a normal kid or just being defiant or a bad attitude, and will punish them and use all kinds of stuff that doesn't work, because punishment doesn't work with ADHD kids, rather than being able to say, oh, okay, well, this is ADHD right now. My empathy now goes up as a parent. I'm going to take the knowledge that I've learned from the therapist and apply it now, so that this becomes a therapeutic experience versus just another hard night. Then our hope is to help that parent, in an ideal world, teach that child's teachers and be that child's advocate for the school setting. And that's a lot easier said than done, because even as an expert who testifies in court on this stuff, I've had teachers tell me to my face, even after them knowing that that's what I do, tell me that I'm wrong. So, not to be a pessimist, but hopefully this inspires you all to spread the good word, because it really can make a huge difference especially when parents are empowered, because they won't feel so crazy all the time. And when they feel more empowered, they're more likely to help their kid navigate a world that does not care about ADHD, does not care about any of that stuff, and really just sees it as another reason Big Pharma is trying to get us all strung out on something addictive. But that's just not the case. So, I'm going to pause this right there, folks, because I've got my next class coming up. I know there's more. We have more classes, I promise. And I know we still haven't made out the ADHD topic, but we actually have, because we've talked about the anxiety stuff already. And trauma in relation to what that does to the brain. If you understand this fundamental stuff from here on out, I do want to start talking about depression, DMDD for kiddos, and then the anxiety disorders and trauma and so forth. And we will jump into that next time. But you know more than what you realize, because the other puzzle pieces start falling in line just from a logical standpoint. They just start to make sense. Okay. Awesome. Well, if y'all have any further questions, or if I can help in any other way, please let me know. And Aaron, I do hope I didn't discourage you with my answers or dodge your questions too much. It's a hard answer, because there's what I wish would happen versus what reality is oftentimes. And reality is more often than not, you're doing the best you can with what resources are available, trying to educate parents and kids or the system as much as possible, knowing that, hey, we're just going to have to work around some side effects sometimes, or we're going to have to just deal with a prescriber who's obstinate sometimes. So yeah, sound good? All right, I am going to let y'all go though, because my kids are coming to say goodnight to me. So y'all have a good evening.
Thank you.
Thank you.
All right, y'all take care.
Thank you.
Bye. My kids.
Good night, Daddy.
Good night.